All right, thank you everyone for joining us for our next PHIND seminar, and hope everyone is safe and well. I'm really excited to have Akshay Chaudhari to be presenting for us today. Akshay is an instructor in the Radiological Science Lab and Precision Health and Integrated Diagnostics sections in the Department of Radiology, who works at the interface of radiology and artificial intelligence. His research interests include developing efficient and safer medical imaging acquisition techniques, repeatable and accurate image analysis tools, and on multimodality sensor fusion. He graduated with honors with a BS in bioengineering from the University of California, San Diego in 2012, and completed his PhD from Stanford Bioengineering in 2017, focusing on novel MRI methods to perform rapid quantitative musculoskeletal imaging. Dr. Chaudhari received the National Science Foundation Graduate Research Fellowship, the Whittaker Fellowship, and the Siebel Fellowship for support his doctoral research. Dr. Chaudhari is the winner of the ISMRM WS Moore Young Investigator Award and has won 6 additional Young Investigator Awards for his work on advanced medical imaging acquisition and analysis techniques, and is a junior fellow of the ISMRM. So it's glad to hear, so many great accomplishments, Akshay, and we're really excited to hear about your talk on moving magnetic resonance imaging towards a low-cost, high-value medical imaging modality. So I'll let you take it away. Thanks so much.
Yeah, thank you for that very kind introduction, and thank you for the invitation to give this talk. Just wanted to make sure if the screen sharing and such looks okay for the time being. Or maybe.
Yep, you look good.
Perfect. So yeah, thanks once again for this invitation to speak at the PHIND seminar series. I'm quite excited to share some of my insights about how we can really think of magnetic resonance imaging, which has traditionally been thought of as a powerful diagnostic modality, but with an Achilles heel of being very high cost and low value. And hopefully by the end of this talk, I can show you some use cases of how we're actually transitioning away from that by coming up with new innovations in how we acquire data and how we analyze this data to really move MRI towards a more high value modality. So let's begin by talking about what is value. When we say things like high value and low value, what does that really mean? And I think in the simplest terms, value can just be defined as some outcomes that you can achieve with a certain task divided by the cost of what that task is. And in medicine, there's another slight variation, a different flavor, where we also add service that a patient receives. And this model has been used quite commonly to assess whether or not any healthcare which is being provided, whether or not that has high value. So quality is essentially the outcomes that a patient receives, while service is the quality of the service that they receive. So for example, if I go to my doctor, if I have injured my thumb recently, and it hurts quite a bit, and if it takes the doctors a year to treat it while I'm in pain, even though my outcomes long-term might be fine, the service that I received may not be very good because it took a long time for that to happen. So that's essentially what the quality and service combination means. And we want to be able to maximize both of these factors while minimizing costs. And that, in a nutshell, is the definition of value from a healthcare perspective. And why is this value really important? Hopefully this chart can give us an indication of why. And here what we're seeing is normalized spending for healthcare costs, which is the large behemoth blue line. And in comparison, we can look at how the gross domestic product of the country has been changing for the last 50 years, and an assessment of how wages have been changing too. And all of these have been normalized for the common economic models too. And I think one of the things that's most obvious here is that healthcare expenditures have grown enormously over time, while the outcomes that patients receive have not grown at the same rate. And economists and healthcare economists especially think that there's probably a lot of different reasons why this may be the case. But I think one commonly attributed model is just the way that reimbursements work. So right now, for a lot of different use cases, we have a fee-for-service structure. So if we take an example of a patient requiring hip replacement or knee replacement, the way fee-for-service-based reimbursement models would work is there'd be a separate reimbursement charge for your patient first going into their orthopedic surgeon. Then there's a separate reimbursement charge if they have to get any sort of advanced imaging, maybe X-ray or maybe MRI. The surgery has a different reimbursement charge, and any follow-up visits have different reimbursements. And with more reimbursements, there's potential for hospitals and healthcare providers to maximize their income. However, this income can skyrocket, which leads to these high healthcare costs. And because of this increase in healthcare costs, over the last decade or so, there's been this transition to move towards a value-based care. And the premise of this value-based care is, instead of reimbursing individual events that occur at a hospital, why don't we reimburse based on the total quality of care that's provided to the patient? So in that same example of total hip replacement or total knee replacement, there'll essentially be one single bundled payment that would take care of a patient 3 days before they come into the hospital and up to 90 days after they actually receive surgery. So with this bundled payment system, now there's an incentive for the hospital to make sure that they minimize any sort of resources that they spend on that patient while maximizing quality, but also really it's incentivized to make sure that the patients don't have any infections, that they don't come back to the hospital, because they'll only be reimbursed once under that bundled system. So as we transition towards this value-based reimbursement systems, it becomes important, even from diagnostic imaging perspectives, to come up with imaging modalities that can actually give us high value. And as we transition into radiology and the value that we can get out of radiology, I think it becomes helpful to look at the current value chain as it exists within this field. So whenever a patient comes in for diagnostic imaging, the first thing that's typically done is a process of image acquisition. And this could be through any modality that one thinks of. Maybe it's X-ray, maybe it's magnetic resonance imaging, computed tomography, positron emission tomography. There's a whole range of modalities based on the specific clinical indication. But it all starts by acquiring some image that's needed. Once this image is acquired, the next step is that someone actually has to read and interpret these images. And this is usually expertly trained radiologists who have to interpret this. Once these images have been read, the next task for these radiologists is to report these findings so that they can be passed on to the physician or the personal care provider that the patient has, and that a medical decision is made to continue their treatment in a particular manner. And each of these building blocks of the value chain have different subtasks too. So for example, within image acquisition, we have to acquire some raw data to begin with. We have to process that in a way that we transform that raw data into a way that we can interpret it from a radiologist's perspective. And there's different techniques in which where we can refine what these images look like. Then within the context of a radiologist read, a radiologist typically takes this large stack of images and they search for a particular feature that they're looking for. And once they find this feature, they have to define whether or not it's healthy or whether or not it's pathologic. And they really try to do this by integrating multiple different sources of information. So maybe there's some other images that the patient has had, and maybe there's access to a medical record where you really want to combine imaging insights along with insights that are specific to the patient. And all of this is used for the final interpretation. And once all of this is done, all these thoughts have to be compiled into a coherent report that gets sent to the patient so that at the end of the day, we can do what we're all in the business of, which is treating patients with the best care possible. So this is complicated value. Probably spend many, many hours talking about all these different subcomponents. But for the premise of this talk, my focus will primarily be on this image acquisition phase, because in the context of magnetic resonance imaging, I don't think there's any questions about how it can be powerful from a diagnostic perspective. MRI has been shown to provide us with great tissue contrast, especially in the context of soft tissues. And we can use it to look at a lot of different anatomies and a lot of different indications. So even though it's very powerful from a diagnostic perspective, one of the limitations that we have with MRI is that these average imaging protocols can require more than 30 minutes of scan time, which really limits the throughput that one can have in an imaging center or in a hospital. And in addition to this, the total costs that are required to buy an MRI scanner, site the scanner, and to maintain it, those add up over time too. And this is probably one of the biggest reasons why the costs and the reimbursements for MRI have traditionally been quite high. But then we might question, why do imaging protocols require so much scan time? And once again, this is a topic of MR physics, and we can spend a lot of time discussing it. But at the end of the day, I think everything comes down to this triangle of trade-offs. With MRI, guided by the physics underlying how the images are acquired, we always have to be able to optimize either between the signal-to-noise ratio of images, how long an image takes to acquire, and the resolution of an image. If we want to increase one of them, one of these parameters, we have to necessarily compromise on some of these other parameters. And from a diagnostic imaging setting, we want images with as high a resolution as possible and enough signal-to-noise ratio so that we can actually interpret these images accurately. But since we want to optimize for both SNR as well as resolution, then we always have to compromise on scan time. And this is one of the biggest reasons why typical MRI protocols require long scan times. And for this particular talk, I really wanted to frame it around a particular use case. And I'll mostly be focusing on musculoskeletal imaging, and specifically the utilization of knee MRI clinically. And I think this is an important problem because even annually in the United States, there's approximately 2 million diagnostic knee MRI scans that are performed. And these diagnostic scans are performed to evaluate acute injuries to soft tissues, such as ligaments, such as menisci, as well as cartilage. And in addition to this, knee pain is also the second most common chronic pain, which is experienced in the US. And a lot of times there's interplay between tissue injuries because whenever one injures soft tissues, there's a higher incidence of future degenerative diseases that end up causing that knee pain over time. So these are quite intricately linked together. And one common utilization of knee MRI is to better understand this complex disease called osteoarthritis. And osteoarthritis is a complex disease that affects all the tissues in the knee joint. And it's been shown that previous injuries to soft tissues increases your risk of developing osteoarthritis, or OA. This disease affects around 20 million adults in the US and costs around 1% of our GDP in total annual cost. So it definitely has a large financial footprint. But despite this prevalence and despite the cost of this disease, we still don't have a treatment for it. And this is because we don't understand the pathophysiological changes that occur in early disease activity, which really stymies the production of new therapeutics and new disease-modifying drugs. So this really necessitates quantitative biomarkers that we can measure at an early phase in disease activity, so we can actually see how this disease manifests from healthy adults to people who have OA. And if we have these quantitative biomarkers, hopefully we can get an early assessment of whether any arbitrary intervention is actually working or not. So to better study clinical knee MRI, as well as osteoarthritis, we need diagnostic imaging. But there's some challenges, like I mentioned. Most of these scan durations take a long time. This is a typical MRI protocol at Stanford, where we require 5 different contrasts with MRI in different scan planes. And on average, this takes more than 25 to 30 minutes of just scan time. And this doesn't count getting a patient situated in an MR scanner, getting the coils put on the patient, and then removing them after the scan. So invariably, it's not uncommon for a 45-minute to 1-hour scan slot reserved just to scan one patient. One reason for this inefficiency is probably because there's repeated contrasts in different planes. So the contrast that we're acquiring here for this knee in the coronal and axial plane are identical. However, due to some inefficiencies in the MR acquisition process, we're limited by SNR. That's why we just have to repeat the same scan 2 different times with different imaging planes. So this definitely is a place that we can increase the efficiency of our imaging. And lastly, from a clinical perspective, we do not acquire quantitative data. Compared to other imaging modalities such as computed tomography, where you have quantitative Hounsfield units, or even PET imaging, where you have quantitative SUV measurements, with MRI, most of the analysis that we do is qualitative in nature. So this really limits how well we can study degenerative diseases like osteoarthritis. And then when we transition from clinical studies to research studies, we face a different range of challenges. So for example, one of the largest clinical studies that was performed to better understand osteoarthritis was known as the Osteoarthritis Initiative, which scanned around 5,000 subjects with knee OA at 8 different time points. However, the imaging protocol required more than an hour of scan time per knee. So this really precluded being able to scan an even larger cohort. And one of the limitations of this was, because of the scan time, we're limited to mostly scanning one single knee. A lot of times knee OA is systemic and it affects both the knees. So being able to decouple changes that we see from acute injuries as well as a systemic immune response, we really need both knees to compare how degeneration is changing over time between both the knees. And one of the other limitations from a research study perspective is that once we have these rich images, it becomes relatively cumbersome to actually acquire biomarkers that we care about, because a lot of times these biomarkers require things like trying to classify a particular image to see whether or not there's a pathology. A lot of times we have to do manual segmentation to trace out different parts of the tissue to see how their morphology is changing over time. So from an overall glimpse, from both a research perspective as well as a clinical perspective, there's a lot of challenges that we face. And when we really put this in terms of a timeline of disease activity of OA, we can see that very early in the disease where patients don't really have OA, they're healthy, they can do whatever they want, they're not limited by knee pain or other pain to maximize their quality of life. And on the other side of this spectrum, patients have immense knee pain and they end up having to undergo things like total knee replacement surgery. And somewhere in the middle is when people start going to their doctors or their orthopedic surgeons because they're experiencing knee pain, which limits their quality of life. And there's some early research that suggests that some of these advanced quantitative MRI parameters can actually be useful at this stage to predict future prognostic outcomes. However, we never really prescribe imaging at this point. The prescription here would be to go home, probably do some physical therapy, ice your knees as much as possible. Even though we have some strong evidence suggesting that MRI and the biomarkers that we generate from it can potentially help future progression and trying to limit the pain. And the fundamental reason here is that we really cannot do this from a healthcare perspective just because our imaging takes too long. So we cannot prescribe everyone with knee pain to go get an MRI scan done. And because of this, the way our healthcare system essentially is lined up is we only end up treating very late stage disease, when in fact our focus should be looking at the very earliest manifestations of what the disease looks like so that we don't have to wait for it to get too bad and we can intervene much earlier in the process. And I think this is a nice, this fares nicely with the whole precision health perspective, where we don't really want to treat sick patients. We want to be able to stop patients from getting sick in the first place. So I think this really is the goal, is to enable fast imaging methods so that we can scan at scale to better understand disease activity. And when I say biomarkers for osteoarthritis, there's a few different biomarkers that we can look at. The first one, which may be the most powerful one, is this notion of the T2 relaxation time. I won't get into the specifics of what the T2 necessarily represents from an MRI physics perspective. That's a long conversation that I'll be happy to have at any other time. But essentially, this is a physical quantity that we can get from an MRI scan. And this T2 has been correlated to the integrity of the collagen matrix structure. So tissues that have a high collagen content, such as the articular cartilage, the menisci, ligaments, they are very sensitive to changes in these T2 values. Whenever that collagen structure breaks down, we can actually see changes in T2 values. And if we can track these changes over time, we're getting a very early depiction of how the tissue is changing internally, even before we start seeing morphological changes for the tissue. In addition to T2, osteoarthritis has also been linked to changes in the thickness of your articular cartilage, as well as the sizes and the location of your meniscus. So if we can really track these over time, we hopefully get a more sensitive understanding of how the entire joint space is changing, so that not only can we study temporal characteristics of osteoarthritis progression, but we can also study the spatial relationships between tissues. For the longest time, osteoarthritis was thought to be just a disease of the articular cartilage, but now that notion is changing and we're really thinking of osteoarthritis as a whole joint disease, but it's still unclear what tissue does a disease start in, how does it spread over time. So hopefully if we can study the whole joint quantitatively, this gives us more insight into disease progression. And lastly, some other biomarkers that are used are these notions of semi-quantitative scoring mechanisms. And one popular one is known as MOCs. Essentially what this entails is a radiologist will just look through the whole joint and then they'll just grade from a 0 to 3 level, what is the pathological status of a particular tissue? Is it degenerated? Is it healthy? Is it somewhere in the middle? And if we can do this for all the tissues in the knee joint, it gives us a very qualitative understanding of how the whole joint is actually evolving over time. So ideally, in a large population, we would like to acquire all of these biomarkers. But there's a few limitations for this. So for T2, we need MRI sequences that have a very high signal to noise ratio. But on the other hand, for looking at accurate morphological changes, we need MRI sequences with high resolution. And to do MOC scoring, we typically require multiple different sequences, which really increases the scan time. So what we're really trying to optimize for here is signal to noise ratio, resolution, as well as scan time. And if you remember the triangle of trade-offs, this is very challenging to do, but I think this has a large population of enabling studies in large populations. So in our attempt to address some of these problems, we developed a new imaging method called quantitative double echo steady state. And essentially, this is a different implementation of how we acquire images with MRI. And with this particular pulse sequence that we call qDESS as an acronym, we're generating two unique contrasts. The first one that we call S+, gives a very nice depiction of the morphology of the tissue. And it has very high resolution. It has good contrast between different tissues. And it can be really useful for just assessing the overall health status of the joint and for looking at morphological changes that are important to do things like tissue segmentation over time. The second echo, or the S- echo, is more sensitive to fluid. And this is important in the context of musculoskeletal imaging because most chronic injuries typically have some increased fluid signal. So if there is an example of a meniscal tear or ligament tear, that'll be really well manifested in this S- image. And what we can actually do with the combination of these two images is to build this quantitative T2 parameter map. We can actually track what happens to individual hydrogen atoms, and we can model this relationship. And using these two echoes as an input, we can also output this quantitative T2 relaxation time map. And since we have high resolution to start off with, we can acquire in one particular slice, one particular imaging plane, and then reformat our scans accordingly to different planes so that we really can go and study the whole joint from multiple different angles to really understand what are the whole joint changes that occur in disease activity. And through different studies, we've shown that this sequence, which we can acquire in 5 minutes only, compared to 20 to 25 minutes of acquisition times for conventional imaging, we can very accurately measure the morphology of tissues. So this is trying to segment articular cartilage in green. We can segment and look at the locations of the meniscus in blue. While at the same time, we can also perform accurate T2 relaxometry. So this is using that acquisition of T2 as a sensitive biomarker of early morphological changes. And with the contrast that we get from this sequence, we can also assess tissue degeneration. So in this particular example, we're seeing some examples of osteophytes, which are bony protrusions that can typically be painful. We're seeing changes in the cartilage. We're seeing some synovitis, all different features that are associated with osteoarthritis onset and progression. And this is all possible with one fast, quantitative, and high resolution sequence. So we really think that, with this particular sequence, we can really enable rapid whole joint analysis and biomarker quantification, not just that can be useful from an osteoarthritis research perspective, but for assessing the overall health status of the joint. And we've shown that, compared to other methods that take more than 40, 45 minutes of scan time, with this 5-minute sequence, we can get most of the biomarkers that we need for looking at very early osteoarthritis progression. And thanks to some great work by Dr. Felix Kogan in the musculoskeletal imaging department, we've actually been able to change the paradigm of how we perform knee MRI. Typically, the standard for knee MRI imaging is you scan one knee at a time, you finish your protocol, and then you just repeat the same thing for the other knee. But we've shown that it is possible to image both knees simultaneously so that we can start getting systemic information and trying to use the joints together in order to get complementary information about how the entire structure of the joint space is being affected. So this can really double the efficiency of how we perform the MRI. So now going back to some of our challenges, we've seen that from a research perspective, we can really limit the scan durations of our, where we can make our scans more efficient. And we can go from unilateral imaging to bilateral imaging without any problems in terms of biomarker acquisition and quality. So maybe for now, I'll take a quick pause to see if there's any questions. I'd be happy to address anything before moving on with the rest of the content.
And feel free to either type in your question or you can raise your hand and we can unmute you as well.
If there's
looks like he has a question. Feel free.
Actually, this is very nice image. I'm wondering what kind of biomarker you are using. You even tell any specific, are you using any protein biomarker, or like here, what do you mean biomarker and what specific things you are using?
Yeah, so that's a good question. So in this case, we're talking about imaging-based biomarkers that we can assess non-invasively. And essentially, when we say biomarker, we're looking for a specific imaging-based outcome that we can use to assess longitudinal progression and change. So there's a few different markers like this that we're using. And this T2 relaxation rate is probably the most commonly used biomarker in the context of osteoarthritis activity, because like I mentioned, it's sensitive to early collagen degeneration. And there have been a whole range of different studies that really evaluate the fact that this T2 changes with the response to acute injuries or different remodeling processes within the joint space. So that is actually what we tend to use most often. From a disease modifying drug standpoint, right now, the FDA doesn't really, it hasn't approved any MRI-based biomarkers of osteoarthritis progression, but there have been a lot of promising studies, and the FDA is quite close, everyone seems to suggest, is using the thickness of cartilage as an imaging-based biomarker of different drugs, which can actually inhibit cartilage thickness loss or actually enable new cartilage growth. So I would say those are the two primary digital biomarkers or imaging-based biomarkers that we tend to use in osteoarthritis studies.
So you are telling a digital pixel-based, how thick or how wide or depth based on that you do. So can you have like any artifact or like a, I mean, basically I'm asking like how much false positive or false negative because it's a digital one. Yeah. So is there anything if there like you feel like accuracy is pretty good, like greater than 90% or 95% or something?
Yeah, that's also another really good question. And I think this relates back to the original premise of the high signal to noise ratio that we need. We've been able to do a lot of validation studies that seems to suggest that the accuracy of these T2-based measurements are high when there's adequate signal to noise ratio in our images. And we've very carefully studied what is the scan-to-scan repeatability. So for example, if I scan myself right now and then scan myself 5 minutes from now, how much does that T2 change? And we've actually shown that the coefficients of variation for this change are actually smaller than the coefficients of variation that one would expect to see in disease activity. So while I don't want to say that this thing is perfectly accurate, hopefully this is giving us a glimpse into very early changes that we otherwise wouldn't be able to see. And I think in that context, it is close to being accurate enough to answer the clinical questions that we have.
Thank you.
Yeah.
We had one written question, which is, what is the stability and repeatability of this procedure?
Yeah, that's a good question. And hopefully I was able to answer that in the previous point. So for things such as the morphology measurements, we're seeing coefficients of variation between back-to-back scans of less than 1%. And with T2, we're seeing coefficients of variation on the order of 2 to 3%. And in the context of disease activity, we see much larger changes over time. So our primary goal is to make sure that the repeatability, as well as the reproducibility of this method, and the coefficient of variation that we get for both are actually lower than those changes that we see in disease activity. And that seems to be the case so far. But we're never happy with that. We're always working on new methods to make the things, to make our imaging faster as well as more stable.
Great, thank you for
Okay,
that.
perfect. So maybe I will keep moving along. So now that we have the sequence that we've built that can give us very high resolution and great contrast, we wanted to see what is the clinical applicability of such a sequence. So if I just go to Stanford Hospital for a diagnostic knee MRI scan, this is what the typical knee imaging protocol looks like. And it takes 20 to 25 minutes of just scan time for the sequences without any additional times for patient setup and tear down. And if we compare this to our qDESS protocol, which in 5 minutes only can acquire these multi-contrast images, we can acquire them in multiple different scan planes, and we're getting simultaneous quantitative information. We wanted to see whether we can actually use this as a drop-in clinical scan, where perhaps only a single 5-minute sequence can replace most of these 20-minute sequence protocols. And we wanted to assess the efficacy of this 5-minute protocol, and we wanted to maintain familiarity of different contrast to radiologists. So we had an initial study where we just looked at qDESS for diagnostic clinical imaging, and then we paired it with one sequence from the traditional imaging protocol in a cohort of around 30 patients or so, just as a preliminary proof of concept study. And we found that there is a high correlation between imaging findings from the conventional imaging as well as findings with this paired protocol. But we did hear that there's consistently hear that there's one particular complaint that our radiologists had for our qDESS sequence, and that there seems to be a trade-off between in-plane resolution. So our sequences were typically scanned in the sagittal plane, but whenever we would reformat this into different planes, such as the coronal plane or the axial plane, even though the images look quite nice, they don't look quite as sharp as the original sagittal images. That's just because of some resolution constraints that we had for fast imaging. So from an improvement area, we wanted to see if we can increase the resolution of these scans without increasing the scan time. So we were once again limited by this trade-off triangle where we wanted to maintain our signal to noise ratio, we wanted to maintain our scan time, but somehow we wanted to increase our resolution. So this is where we turn to some advances in artificial intelligence to be able to enhance the actual imaging scans that we acquire. So here's an example of a routine scan that our radiologist would assess. This scan would take 5 minutes of scan time. And here we can see this thin black band. This here is the medial collateral ligament. And it's very hard to see that because it's entirely blurred out because of the multiplanar reformatting. But when we actually take this image and we feed it into a convolutional neural network that we designed to enhance the resolution of MRI, we can see a much better depiction of this medial collateral ligament. And when we compare this to a scan that took twice as long to acquire, we see that there's pretty high concordance between the imaging appearance from our neural network scan that we call deep resolve versus the ground truth scan that required more than 2 times the scan time. So we really wanted to see whether we can combine our fast imaging with some of these artificial intelligence-based approaches for image quality enhancement. And we wanted to see what the diagnostic benefits of this would be. So in a different cohort of around 51 patients, we scanned patients who were coming in for a routine knee MRI scan with the conventional protocol as well as the qDESS protocol. And these patients went on to get subsequent arthroscopic surgery too. And with this arthroscopic surgery, we had some nice reference measurements for injuries to the meniscus, injuries to the cruciate ligaments, and injuries to the cartilage. And what we wanted to compare was the relative sensitivities and specificities of our qDESS imaging and the conventional imaging protocol to those findings that were found during arthroscopic surgery. And for the menisci and cruciate ligaments, we basically saw that there is similar sensitivity and specificity values. But with cartilage, we found that qDESS had a much higher sensitivity, but a slightly lower specificity than the conventional imaging protocol. And this was a little bit perplexing for us, so we decided to investigate a little bit further. So when we used just the qualitative morphological images with qDESS, we saw that our sensitivity and specificity was pretty similar to the conventional imaging protocol. But when we asked our radiologists to assess the qDESS images, as well as the quantitative T2 maps which are generated, we saw that the sensitivity to lesions was much higher. And interestingly enough, within these cartilage lesions, there's different grades of lesions. And we saw that there's much higher sensitivity for the earliest cartilage lesion grades that was depicted because of these T2 maps. So we surmised that there's a lot of potential for these quantitative T2 mapping approaches to help in diagnostic clinical imaging because it makes you more sensitive to very early changes, with perhaps the caveat that the specificity was a little bit lower, but then again, this specificity was acquired using arthroscopic surgery, and where cartilage lesions are graded by essentially poking the tissue and seeing what the stiffness and what the integrity of that tissue is like. So perhaps if we're seeing the very earliest biochemical changes with T2 mapping, we actually cannot assess those changes with arthroscopic surgery, which may be one reason why the specificity might be lower. And this is based on a large body of evidence which suggests that changes in T2 precede morphological changes by easily 2 to 3 years. So perhaps that is one explanation for why our specificity was a little bit lower. So using this particular study where we paired our fast quantitative imaging sequence, qDESS, with an artificial intelligence-based super resolution platform, we saw that in our cohort of 50 patients, we had high concordance with the diagnostic knee MRI protocol findings. We had similar sensitivity and specificity between qDESS and the conventional imaging protocol. For the first time, we're actually able to use quantitative T2 mapping in a diagnostic imaging workflow. And this is because T2 has been around as a parameter of interest in quantitative MRI for a long time, but we've never been able to efficiently acquire that parameter. And with qDESS, we can simultaneously acquire images that help us assess joint injuries, but we're also getting these T2 maps for free. And we also showed that the super resolution method was able to enhance image quality and increase the diagnostic quality of these images. And I once again want to emphasize that both the T2 mapping and the super resolution are quote unquote acquired for free because we didn't have to change our acquisition protocol. These were simply post-processing steps that we could take on the efficient acquisition that we've had already. And perhaps one of my favorite examples to share here is one patient with a suspected tear of their meniscus. So this is a conventional T2-weighted MRI scan, which is commonly used to assess meniscal tears. And we can see a slight increase in signal. The meniscus is this triangular structure, and the meniscal tear is a small line which connects to an articular cartilage surface. So this meniscus tear is depicted similarly on your T2-weighted scan, as well as the 2 echoes of our qDESS scan. We can really see that meniscus tear pretty well. And besides that meniscus tear, we can't really see anything else that is different in these images or something that may be degenerative. Especially the articular cartilage looks fine. But when we add these quantitative T2 maps, we can see that the region of articular cartilage, which is under my mouse, the green and red, that shows multiple regions of degenerative changes. Normally, healthy articular cartilage would be consistently this green color with a T2 time of around 40 milliseconds. But with our T2 parameter map, we can see multiple different foci of hyperintense T2 values, even though the underlying morphological images look completely normal for all of these other scans. So I think what we are seeing for the first time in a clinical setting is the earliest degenerative changes in articular cartilage, which we've never really been able to see thanks to these quantitative T2 mapping approaches. And when this quantitative T2 mapping was actually used in a clinical perspective, we saw that our sensitivity to cartilage lesion was increased by 20%, like I described. But also, when radiologists just read the T2 maps like they would with any other image contrast, they said that it increased their diagnostic confidence in roughly 77% of scans or patients that they looked at. So there definitely is a lot of potential to incorporate these quantitative imaging methods into clinical practice, and that has never really been done before. And I think this relates really well back to high value MRI. So if we look at our definitions of value, we see that our value is just the quality and service divided by the total cost. So with respect to some of these fast quantitative imaging methods, we see that the quality of information that we receive is actually more because we're getting information about these quantitative parameters, which we haven't been able to get before. And the service that's provided to the patients is increased also, because instead of being still in a claustrophobic MRI scanner for 20, 30, 40 minutes of scan time, now they only have to tolerate one scan, which is 5 to 6 minutes total. And because of this, there's probably fewer chances of them moving, causing to fewer chances of scan repetitions. So overall, the quality and service that the patients receive is much higher. And at the same time, for hospitals, since this can be used to actually maximize throughput, the costs are actually going down. So overall, I think this is a perfect use case of how we can use advances in developing new MRI methods and developing new methods to process this and get more information. And we can use these in a cohesive manner to really increase the value that we care about. And maybe I'll pause once more here to see if there's any questions about some of the clinical perspectives of these high value imaging tools. If there are any.
Yep, it looks like we have two in the question and answer here. Why does the thickness of the cartilage look thicker on qDESS+? What is the standard contrast weight for cartilage thickness measurement? Is this thickness measurement done routinely clinically?
Yeah, I think the articular cartilage here looks much thicker than the T2 weighted scan here because the contrasts that we're looking at are much different. So this articular cartilage is actually divided into separate subsections that people tend to refer as a deep cartilage, which is at the interface of the bone bone surface. And that has different MRI relaxation parameters. And in this T2 weighted scan, a lot of that deep cartilage has actually decayed away. The signal from that isn't really existent in this image. That is why we're mostly seeing the superficial layer of cartilage. The standard for measurement of cartilage thickness is this DESS scan, but there's a different variation of DESS that's used. So typically in qDESS, we're seeing these two different echoes, but the traditional and the gold standard measurement for quantification of cartilage thickness is another pulse sequence which simply combines both of these echoes. It just adds them up together. So we're basically seeing the full thickness of cartilage with these two scans. So perhaps that's one reason why we're seeing a different contrast between these two images. And I think this goes back to the point of why we need multiple different contrasts clinically to begin with, because each contrast provides a slightly different glimpse into the structure of the joint, and each contrast has different pros and cons. And with qDESS, we're simultaneously able to generate these different contrasts that we can use for morphometric analysis, as well as a clinical analysis of injuries. So hopefully that answers the question.
Great, and we've got a couple more here. So from Kevin Thomas, really cool. Could deep resolve image small anatomical features that are missing from a test set patient, but are found in most training set patients? Anything in your training procedure to prevent this?
Yeah, that's a really good question too. So we're, if I can go back to that slide. So basically what we tried to do with this particular image resolution enhancement method is to be able to train on patients that have different grades of osteoarthritis. So during the network training, the algorithm has actually been, the algorithm has actually seen different manifestations of tissue injuries. So this algorithm has actually seen osteophytes, it has seen different ligament tears, it has seen meniscal tears. And we actually ran a study recently, and it's published in JMRI, where we tried to measure the quality of the segmentations that are performed from these super resolution images, as well as the ground truth images. And we saw that there's a 98% overlap in the cartilage surfaces with this deep resolve enhancement method. And that's a really high accuracy in terms of what the tissue is actually segmented. And in addition to that, we also had 2 radiologists count some very subtle features called osteophytes. And I think those are generally evident here. So normally the bone surface should be smooth, but we see like a small protrusion right here. And these osteophytes are thought to be the earliest physical manifestations of osteoarthritis activity. And we had radiologists score these and grade whether or not they're able to see them in the image enhanced scans, as well as the ground truth scans. And we saw a very high concordance between those two. But we're always trying to make sure that our deep learning algorithms don't miss any particular features. So when we're actually training these algorithms, what we train for is not a full image from scratch. The image that our network is actually taking in is this input image. And we're only trying to create differences between this input image and the ground truth images so that the content that our neural network is creating is sparse. And we actually penalize the network to create anything at all because we're concerned about the network creating other artifactual measures. So that's how we're actually enforcing, trying to create only features that the network seems are highly relevant in that case.
Great, and then it looks like we have another one. What is the path to get clinical adaptations?
Yeah, that's a work in progress for us too. And we're trying to figure out the best answer. And I think there's a few different approaches. So the first thing is to make sure that some of these systems can be deployed in the clinic robustly. A lot of new imaging sequences that are developed, only the people who develop those sequences can run them because they require very specific parameters that are set on this. Maybe you don't reconstruct it in real time on the scanner. So being able to come up with a robust deployment package becomes very important. So that way MRI technologists at your imaging center or at the hospital can run these all the time. So I think robustness is important. And then just doing validation studies in large populations will be important. We have some preliminary studies in 30 subjects and 50 subjects, but to get real clinical adoption, I think it'll be important to do studies at multiple different sites that see different demographics of patients and just really be able to scan more patients to see what is the overall efficacy. So that is the ultimate goal, and that is what we're slowly but surely trying to transition towards.
Wonderful, and we got one more.
Yeah.
How are these methods stable for any perturbations in image or sampling methods due to slight movement of patient or small anatomical differences between people, etc., differences in scanners?
Yeah, so I think when we train these algorithms, we try to account for some of these differences too. So during our training, we can actually augment our training data set by creating new data that might be motion corrupted because we understand what the MRI physics interpretation of these models is. So we can actually create from a normal data set what a motion corrupted data set might look like. So that in that manner, we can build up these nice data augmentation steps. And in addition, we can also have these measures called data consistency measures. So essentially, to make sure that we're just not creating new image features or new artifacts, what we see in our images that has to be consistent with the required data. And because of this consistency enforcement, we're actually not introducing too many more artifacts. But once again, like I mentioned, these are pretty advanced computer vision methods, and there's new literature coming out with better ways to train this, and we're always thinking of new ways to make our systems more robust. So maybe I will keep moving along for my last few slides in the interest of time. So I think the general premise here is that with some of these qDESS-based methods, we're seeing high-value imaging. But I also want to mention that there are other methods that can also be pretty powerful in this context. And one method that I wanted to specifically point out is this notion called T2 shuffling, which uses a different mechanism for sampling. But during the reconstruction, we can actually reconstruct 3D volumes at different imaging contrasts. And this actually has been implemented at Stanford Hospital as a standalone scan. So if a patient has insurance pre-authorization, they can actually come in and get the scan done on them in as little as less than 10 minutes. So there's a lot of different ways forward when it comes to these high-value approaches. And most of the time, for most of this talk, I've really focused on these image acquisition-based methods. And with image acquisition, we're able to solve quite a few challenges that we see clinically as well in research studies. But I think one check mark that we haven't been able to check off just yet is this premise of analysis. And this analysis really comes into this reading and interpreting images phase. And there's a lot of approaches that we're trying to develop for that too. For example, with some really nice work being led by one of our students, Arjun Desai, we can come up with automated segmentation to automatically segment out articular cartilage in different regions of your knee joint. We can segment meniscus so that downstream analysis of looking at thickness and looking at T2 becomes much easier. And this can be added with a variety of computer-aided diagnoses algorithms, a lot which are being developed at Stanford to really help radiologists interpret these images faster. And I really won't go into detail for a lot of these algorithms because that could be another talk of its own. But it is interesting to think that there's a different notion of value that these deep learning-based analysis algorithms bring in, because they're not really changing the quality of care that you receive. It's not really changing the service that the patient sees. It's really driving down the costs so that these methods can be analyzed and deployed at scale. And hopefully that is one way where we can limit this cumbersome analysis standpoint. So I think a general vision here going forward in terms of high value knee imaging is maybe one day we can actually replace these knee radiographs, which are the first line of imaging that most patients receive, with a very rapid and quantitative MRI scan. Because for a lot of patients, if they come in with a suspected tear of their ACL or meniscal tear, they'll get radiographs performed anyway, even though they may not provide the diagnostic information that's needed, and they end up needing to get MRI anyway. So for particular indications and use cases, why not just skip this step and make things more efficient? So I think that can be a really tenable vision in the next 5 or 10 years or so. And I think for the last 5 minutes or so of this talk, I wanted to share a few use cases of where other high-value methods can be used in MRI. And I think in the context of musculoskeletal imaging, one big challenge that we face is trying to do MRI around metallic implants. So this patient has an implant in their tibia, which is seen here, which leads to serious geometric distortions because the metal implant creates a changing magnetic field. And because of that, it becomes very challenging to image the joint without those geometric distortions. We've come up with new methods where we can limit those distortions. So this is the same patient with a different sequence. And even though we see some artifacts from the metal implant itself, these dark and bright regions, we can at least assess the joint morphology quite well. But the downside of these metallic implant measurement sequences is that it requires more scan time. So recently, in a lot of work being led by a graduate student at Stanford, Philip Lee, and Dr. Brian Hargreaves, they've been able to come up with new approaches of imaging around metal. So for example, here we're seeing an example of a hip implant, which the reference method requires 5 minutes of scan time. But with the new technique that's been developed called robust principal component analysis, this 5-minute scan time can be lowered to almost 1 minute. And if we zoom in on this particular hip implant region, we can see virtually no difference in image quality. So I think this really has the potential to change how we image patients that we might have not been able to image before and had to resort to other imaging modalities. And I think there's a lot of potential to translate some of these methods even beyond musculoskeletal imaging. So for example, we've used some work on deep learning where we're able to take a diffusion-weighted MRI scan that typically has only been used in the context of research studies. And this is because it requires 13 minutes of scan time. And using deep learning, we're able to reduce the scan time to less than 2 minutes. And here we're seeing regions of a stroke that are that can be seen nearly identically between these two scans. And we can really see the asymmetry in this particular region between the right and left lobes. And we're able to show that this rapid diffusion MRI could actually be predictive of outcomes after the stroke too. So I think techniques like this have potential to make high-value care for neuroimaging possible too. Another example that I'm really excited about going forward is this notion of breast cancer screening. So normally, mammography is the go-to imaging tool for breast cancer screening. And this graph roughly shows you on the x-axis what the aggressiveness of different tumors is and a corresponding sensitivity of detection using mammography, as well as using MRI. So let me remind you that mammography is a standard and MRI has not really been used from a routine basis, but it's been used as a research perspective right now. And as the grade of the tumor increases, our sensitivity to MRI actually goes up. And here's a really nice example about comparisons between mammography and MRI. This is an example of a two-view digital mammogram. I'm not really an expert in assessing mammogram images, but nothing seems too out of place in this mammogram. But then for the same patient, if we use this concept of a fast MRI protocol, we can inject gadolinium contrast and image before the contrast and after the contrast. And using a difference of those two images, because the tumor selectively takes up this contrast, these tumors light up really well on those subtraction images. So there really is potential to go from this low sensitivity mammography technique to this high sensitivity MRI-based method for widespread screening. And while this is promising, one of the downsides of this fast MRI is still the notion that requires contrast. Gadolinium contrast is a contraindication if you have lower renal function. It's expensive and it requires an expert to actually inject the contrast. And the use of contrast, even though promising, can really still limit how much screening can actually be performed in terms of throughput for patients. So here is an example of how non-contrast images look like with MRI. On the left, we can see a sagittal T2 weighted scan compared to a dynamic contrast enhanced scan. Now on this contrast enhanced scan, we see a tumor appearing with high conspicuity, but with conventional imaging without contrast, we see a bright region of edema, which appears nearly identical as a tumor. So it's really challenging to differentiate these. But thanks to some work being done by a great team at Stanford, they're developing some conventional MRI sequences that do not need contrast to be able to look at that same tumor. And we can see that using another variation of this DESS sequence, the tumor appears with similar conspicuity as the dynamic contrast enhanced scans. And we can actually lower the contribution of the signal in the edema. So this is, I think, an exciting way to move ahead with breast cancer screening techniques that don't require contrast and can be widely deployed and can have implications for other oncology-based screening methods too. So maybe just wrapping up and as conclusion, hopefully through this talk, I've shown you that using advances in coming up with new MRI techniques can really improve the quality of care that patients receive while simultaneously being able to reduce the costs and really leading towards high value care. Some of these high value MR examinations can really enable these screening exams from a wide perspective. And I think this really makes sense from a precision health perspective, because if we can really study the earliest manifestations of disease hopefully we don't have to wait till it becomes too bad and before spending too many resources trying to treat it. And lastly, using some of these new quantitative imaging metrics, hopefully this opens up this perspective of opportunistic evaluation of potential biomarkers. So for example, if we implemented the qDESS sequence clinically for just routine clinical evaluation, we're at the same time getting so much information about those T2 parameters, about cartilage thickness in a cross-sectional study, and hopefully that can help us gain better insights about the pathophysiology of disease without having to change how we perform our routine clinical care. So with that, I'd like to stop for the final phase of questions. And here's my email address if people have questions or comments or would like to work on any of these techniques. So I'm happy to open the floor again.
Great, and we have one in the Q&A that was there before, so we'll go into that one first. What was the magnetic field strength of the instruments you used in your studies in Tesla?
Yeah, so we used 3 Tesla scanners, which is essentially the clinical norm, I would say. There is a lot of research being done on 7 Tesla scanners too, but that's only from a research perspective. We wanted to stick to the scanners at 3 Teslas that are widely available all across the world to do our research studies, so that the techniques that we develop can really be deployable across different sites and across different scanners.
And then looks like we have somebody who has their hand up. So Arut, you're able to talk if you want to ask your question.
Yeah. Hey, Akshay and Ashley and Ryan, thanks so much for organizing this talk. So my question, so kind of you said after deep learning technique applied, this 77% increased the confidence of the diagnostic of the osteoporosis and other imaging things. So I'm wondering how early this confidence increases. Like, for example, you try to say this imaging technique, especially after deep learning, enhance the contrast will help very early. How early? Like, for example, that 77% comes out from advanced stage for diagnosis or very early stage?
Yeah, so regarding the diagnostic confidence, that was more in relation to the quantitative T2 map that our radiologists studied. So with qDESS, we get these 2 morphological images, and then we also get this quantitative T2 map. So instead of just reading only those 2 images, we asked our radiologists to review the quantitative T2 map, and it was that T2 map that increased our diagnostic confidence in around 40 out of the 50 patients that we studied. So that was how their confidence increased. But in the context of the question and in looking at temporal changes, that's a good question that I don't think we have a very good sense for, especially in a large population, is how early can we see the changes? And the reason we don't really have a very good answer is because we've never been able to apply these techniques in a broad population because it's just too expensive to scan with it. There's some smaller cohort studies that show that we start seeing changes in cartilage T2 roughly 2 to 3 years before there's any morphological changes that are visible. And this again depends on the cohort that you're looking at. So there's different cohorts that exhibit faster changes. So if you tear your ACL, you're more likely to have early osteoarthritis compared to a cohort that did not injure their ACL. And in that cohort, it's been shown that we can see T2 changes within 1 year after your injury too. So I think that question is still up for debate just because we haven't been able to collect as much data as we like. And hopefully with these fast imaging sequences, we can deploy the method widely to really start collecting data sets in large populations to precisely answer that question.
And if no question, second question, it's kind of, so even the second segment itself, I want to ask, so the gadolinium contrast agent is clearly the contrast so high. And then second image you showed really very nice one. Yeah, this is the one.
Yeah.
But compared to this gadolinium and this one, so how far this contrast is really, really very good. Seeing image is different quantitatively. I'm asking honestly how much is clearly we can able to see, because this is looks like advanced tumor. If you want to apply in very early stage, how far we can able to pick up using this, using your method or deep learning method?
Yeah, so it's a good question. And I don't think I am best suited to answer this question because I'm not a radiologist, but I think that is a very good point. So maybe going almost back to this curve where different grades of tumors have different imaging manifestations. And generally it's been shown that with contrast enhanced MRI, we have high sensitivity to higher sensitivity to these early grade lesions. But almost similar to my previous answer, we've never really been able to deploy these screening methods in a large population. So it'd be really interesting to evaluate what your sensitivity and specificity really is for different grades of disease activity too. I don't have that data available off the top of my head, mostly because I'm not an expert in breast imaging, but if you're interested, I'm happy to chat more about this and try to connect with the people who are the experts.
Thank you so much. It's very nice talk. Thanks a lot.
Thank you.
Great. Yep. It doesn't look like we have any more questions. So yeah, thank you so much for joining us today and for your presentation.
Yeah, thank you everyone for joining, and thanks for inviting me again.
Very welcome. Thank you.